Good afternoon, everybody. Thank you for joining us here on Community Connect, and thank you to the Union for giving us this opportunity to present some of what we think are interesting solutions for TB and for COVID. And we're really looking forward to being with you. Thank you for joining us to be able to discuss afterwards. So I just wanted to run through a little bit the session. So my name is Rachel Cadell-Monroe, and I am the founder and executive director of the Sea Change Initiative. I'm based here in Montreal with my two colleagues. First is Jessica Faber, who's our community readiness coordinator at Sea Change. And secondly, Peter, who is the medical director, Dr. Peter Saranchuk, who's the medical director at Sea Change Initiative. My background is I've spent many years working with Médecins Sans Frontières in the humanitarian field, and I set up Sea Change 2 years ago to really bring a kind of different approach to some of the ways that we work with communities. In terms of the session, what we planned was to have it in 3 parts. So I'm going to start off telling a little bit the origin story of Sea Change and how we came to the Community First COVID-19 roadmap. And then after that, Jessica is going to come in and walk us through the roadmap and show a little bit how it works and a few of the stories of where we're using the roadmap around the world today. And then finally, Peter is going to come back and link up COVID and with TB and the work that we're doing in Nunavut and start thinking about some of the directions moving forward. And then we'll end there and have at least half an hour, maybe a little bit more for your questions and comments. I'm going to be moderating this session as well. So if you, when you get to the questions and comments, if you want to put questions in the chat, you're very welcome to, but if you'd like to actually speak, I can activate so that your voice comes on. It's always nice to hear people live. So feel free when the time comes to put your comments in the chat or to put your hand up with a little hand signal. Just for everyone to know, this session is being recorded as well for the Union to be able to post it after the event. So as I mentioned, my background is very much in humanitarian work with Médecins Sans Frontières, Doctors Without Borders. And I started off, as many people in MSF do, starting in the projects on the ground. And slowly over time, I moved into different more management positions, board director positions. And as I was sitting in a much higher policy position on the International Board of Directors of Médecins Sans Frontières, I decided that I really wanted to get back down to the ground and find a new way to work with communities, because I saw more and more how communities were becoming not really central actors inside their own health responses. So we set up Sea Change here in Canada, and it came really after a clarion call from Stephen Lewis, who I'm sure many of you know of. He's been an extremely strong advocate for HIV, AIDS, and for TB in more recent years. And I know that he's been also speaking at some of the Union events in the recent past. So Stephen had been invited by the Inuit communities to visit Nunavut, which is up in the Canadian Arctic. And he'd been asked to go there to witness what was happening to Inuit people as a result of tuberculosis. And when he came back in the summer of 2017, he was absolutely horrified by what he had seen. He could not believe that, people in this day and age in Canada, in one of the richest countries in the world, were actually dying from tuberculosis. This has been a secret, silent epidemic in Canada that's been going on for decades and very little known about in the general Canadian population. But what we do know is that the Inuit suffer at least 300 times more from tuberculosis than any Canadian-born non-Indigenous person. So it's a really striking inequity and injustice inside Canada. And many of us believe that this is very much a strong result of the history of the systemic colonized approach to health in the Canadian North, and even systemic racism. So when I heard Stephen's call, I felt compelled to respond. And so I started to work to see what would be the best way to work with the communities. And we partnered, a few of us started, we went on a visit at the invitation of the government of Nunavut in early 2018. I was there with Peter and 2 other colleagues, and we travelled around the communities and realised that there was very little understanding at the community level of what TB was. And on top of that, there was a very huge trauma associated with the history of TB in that area. And we'll talk a little bit more about that later on. But suffice it to say, we realized that we really needed to work at the community level with communities. And we went and decided to partner with an Inuit organization called Illisatavik Society, which is based in a village, hamlet called Clyde River. And this is really out in the eastern side of Nunavut, on the Baffin Island. And Illisatavik Society is an extremely unique NGO. It was set up over 20 years ago by the community because they felt that the government was not responding to the community needs and what they saw as their priorities. So they decided to set up this organization so that they could deal with what for them at the time was a priority, was their suicide epidemic. They had huge numbers of young people taking their own lives, and they wanted to do something to stop it. So they set up some extremely creative and innovative community-led workshops, which were really to develop their resilience on mental health issues, to be able to train counsellors that could work inside their community and do things their way with their own responses, which took into account their cultural specificity and really was respectful to how they believed that they could do it. It's been an absolutely groundbreaking program. And so as we discussed with Illisatavik, we discussed how we could use that approach to really talk about TB. So we did that, and we started to work on developing workshops in the community that would be trauma-informed, and that the community would design themselves. And this was really the birth of this idea of a community-first approach, which you'll hear us referring to through the course of this presentation. It goes all the way to the name of the project. As you can see, it was called We Could Pass the Flame. And this was a name that the community came up with, and it really made this project something that was owned by them, that they felt was theirs, that they felt really much more than just a recipient of. They actually feel as the designer of this project. And We Can Pass the Flame relates to an extremely important cultural practice in Inuit communities, which is around this little kuluk that you can see on the right with the hand where the flame is going on above. And that kuluk is extremely important traditionally. It's used for cooking, it's used for heat. And the story behind this is that the idea of the flame lighting up is what Sheila, our TB coordinator from Clyde River, tells us is as the flame spreads along the wick and the oil comes out from the kuluk to light it, this is really like the community gaining knowledge. And as they get more knowledge about tuberculosis, the flame is as that information passes through their community. So it's an extremely powerful way of explaining it, and also extremely powerful for the community themselves in terms of their identification and ownership of the project. These workshops, we did the first workshop in January of this year, and people, as you'll see in this quote, people feel that they're now able to heal themselves because they've been able to talk about what happened to them with TB in the past and how they can move forward into the future. So if we can move on to the next slide. From that work on TB, we were having great plans to move on with other workshops moving forward, but then of course COVID-19 arrived. When COVID-19 became a real issue in Canada in, I'd say March 2020 was when really the public consciousness was awoken, and here in Quebec that was when the lockdown began. It was around March the 12th. Then the community was extremely alarmed. They were terrified. They have this extremely long history of tuberculosis. They remembered the Spanish flu of 1920, and they came to Illisatavik and to Sea Change and said, can you help us to have a response that's meaningful for us so that we can make sure that first that we're prepared if for a potential outbreak of COVID in our community, and that we can do as much as possible for that to prevent that from happening. We don't know where to begin. So we started this first idea of an emergency response plan, which we drew up with Ila Satsovic and the community. So we co-created this emergency plan. And then they put that into practice. We set up resources, we set up a committee, we got hired some more people to be involved in the response. And we also helped to send up some PPE and some materials that they needed in that community. And so the community was prepared. And in fact, there was a suspected outbreak in Nunavut at some point, and the community was extremely ready to respond because they had all the structures in place. And they talked about how much comfort it gave them to be able to know that if something happened, they would be able to respond. And I'm very happy to report that there is still no case of community transmission of TB in Nunavut, because very early the Nunavut government closed down the territory. But there have been some cases of COVID-19 in Nunavut, but in the mines. But we're very happy that nothing's happened in the community. But if that happens, if there are cases, Clyde River will be ready to respond. So we did that, the community was very happy, and then they said, but there are other vulnerable and isolated communities in Nunavut, but also in the world that could benefit from this approach, this way of doing it. And so from that, we started to think about how would be best to spread the word about it. And so in April, Jessica came on board, and we started to move this onto a website. And this is what has now become the Community First COVID-19 website. As you can see from here, it's in 5 languages. It's translated into Inuktitut, that's the top one, in Spanish and French, in Portuguese, and in English. And so that's now available for people. And Jess, I'm going to hand over to you. I'm just going to quickly pass on to the next slide, which shows a little bit how the roadmap works. So the idea of the roadmap is it takes the user, which can be a community leader, it can be any community member, it could be a community-based organization. And it basically takes you through a step-by-step approach to how to organize yourselves, how to prepare yourselves, and how to respond to COVID-19. And then we added more recently a 4th step, which is what happens, how do you sustain those measures that you put in place? Because as we get on to the 2nd, 3rd wave of the pandemic, we have to be able to keep up those practices. And so that's a little bit the roadmap. We're really excited to share it with you. I'm going to hand over now to Jess, who's going to take you through a demonstration of how it works. Thanks, Jess.
Thanks, Rachel. So yes, as Rachel said, I'm going to take you through the roadmap. The URL is just here. I invite anyone who wants to log onto your mobile phone, and you can put this URL in and follow along on your phone as well. Or I'm going to continue to share my screen, and I'll take you through how the roadmap works. And I just see there's something in the chat. Okay, so this is the website of the Community First Roadmap. As Rachel mentioned, it's available in various languages, so you can choose your language at the top. And the way that we have organized the information in this roadmap, as Rachel mentioned, is to organize, prepare, respond, and sustain. So the idea is that a community leader would go into this site, and they can form a committee and go through to actually create an adapted plan for their community and use some of the resources. So I'm just going to give you an overview here. In organize, we have steps such as beginning to coordinate with the health authorities, identifying those high risk and vulnerable groups, sealing off the community, communicating the key messages, provide food and essential items. And then in prepare, this is beginning to get ready if there is actually a case. So getting PPE, providing specific supports to vulnerable groups, hiring community health workers, preparing isolation and quarantine. And then we have respond. And this is what happens when there actually is a case. Such as how to detect cases with and without testing, isolating cases, tracing contacts, supporting mental health and wellness. And then we move on to sustain, which are just some recommendations for how a community could actually keep up these actions. So I'm just going to take you through a couple of the steps, and then you're perfectly welcome to go through on your own in more detail. And we also offer virtual trainings to community leaders. So if you're interested, our team would be happy to really go through in detail with you or your team and help you to actually create your plan. So the first step before even beginning that we have on here is creating a community first COVID-19 committee. And this is the format of every page of the website, every step. We have a couple of suggested items to consider, such as who to include in your committee, how to create a virtual platform to discuss, setting priorities, etc. And then on each page, we also have some example resources that communities can either use, adapt, use for reference as they create their plans. So as Rachel mentioned, this all began in Clyde River in Nunavut, and we have several of their resources on the website as well. So you can see, for example, how they created their committee, who was involved, what they discussed, what the purpose of the committee was, and how it worked. So things like that, and that's all throughout the website from different communities. I see there's some comments on the chat, so I can't. Okay, Rachel, please just let me know if there's something I need to.
No, don't worry, I'm just.
Okay, so I'm not sure. Great. So just the next step before actually beginning the roadmap is using the checklist to develop your plan. So that's kind of a complementary tool to this website. And basically what this is, it's an action plan and it's an outline for a community to actually create their plan. So the idea is that the committee can download or print out this outline or checklist, and then they can go through as they're going through the roadmap and actually edit it to meet the needs of their community. They can take out the steps that aren't relevant to them, add any steps that are, add in who's responsible for what, which kind of high risk and vulnerable groups are in the community. And also they can use the resources from the roadmap website and add them into their plan here. And the most important thing about the resources is that they're all verified by our curation committee, and they're all in line with WHO guidelines. So the idea is to really be offering community level resources, simple infographics, very simple guides, to try to avoid this infodemic, as it's been called. It's over saturation of information on the website that can just be so overwhelming. And this is what we found in the experience of Clyde River. So that's what we're trying to do with the resources. Sorry, just to go back to the website. So I'm just going to take us through a couple of different steps. And of course, communities are going to be at varying levels, varying stages in their pandemic response already. So really, they may skip all the way through to respond. And they can go and pick and choose each step in any order, but this is the order in which we put it together if a community wanted to go through all the way step by step. So I'm going to go to communicate key messages, for example. Just to show this can work. And so as I said, on each page, there's some suggestions, raising awareness about symptoms, prevention, mental wellness, combating myths, stigma, and rumors. So a few simple suggestions, and then this is a page where we actually have a lot of resources because communications is so important. So for example, we have a page full of infographics that communities can use, and these are from all different sources, some large organizations such as MSF, other small community organizations. So infographics on masks, as well as general prevention. You can click on these, make them bigger, they can download them. Infographics on hand washing, distancing, and mental health and wellness. things like that. There's also scripts for radio if a community wanted to make their own radio show to transmit key messages about COVID. That's something that Clyde River did. So we have, just very simple guides and templates, outlines, and case studies as well on this website. And just going back to our main page, I'm also going to take us to the page on supporting high risk and vulnerable groups. And this is also a really key focus of this roadmap, is that ensuring the most vulnerable in those vulnerable communities are really protected and supported as well. So there's a big emphasis on that. So we just have suggestions such as providing food and essential items, mental health and wellness support, access to treatment for community members with comorbidities. And then we have specific resources for each of these different high risk and vulnerable groups. And of course, there could be more vulnerable groups, but these are the ones we have. So for older people, infographics about how to communicate these risks, some resources for community members with TB, and groups who could otherwise be vulnerable, such as women and girls, survivors of sexual and gender-based violence, people experiencing homelessness, people living with HIV and AIDS, migrants, people with disabilities. So I know it might be hard to see on here, but again, I welcome you to go in with your own time and click through some of these resources. It's just a selection, but there is quite a bit here. And okay, going to go back again and just take us through one more step from the response section this time. So you can go supporting mental health and wellness, another really important step. And there's a lot of resources that community leaders can choose from here as well, such as tools for dealing with anxiety during COVID, some First Nations resources in Canada on supporting mental wellness and specifically mental wellness for elders and also children. And then some supports as well for community health workers who are going to be addressing mental health and wellness. So those are just a couple of examples of steps from the different sections of the roadmap. And as I mentioned, you could go through to the bottom of each page and click to the next one. And just the very last section is sustain. So again, just re-emphasizing some of these really important steps and offering some considerations on how communities can continue to really sustain those actions through future waves of the pandemic and keep adjusting life as they know it. So I'm going to go back to the presentation now, Rachel, unless there's anything else you think we should mention about the roadmap.
No, that seems great, Jess.
Okay.
I think we can go back to that.
Great. So we've come a long way since May, really, when we first launched this website and did a lot of outreach with communities in Latin America through one of our partners, the Association of Médecins Sans Frontières in Latin America. And now there's many communities in Mexico, Peru, Honduras, Colombia, and now Kenya actually using this roadmap to support their communities. And we've since expanded the initiative to encompass more than just this actual step-by-step guide for creating a community-first COVID-19 plan. So we call that the roadmap, but we're also doing workshops and trainings with communities. So we can do a virtual session with community leaders going through step-by-step, or more specific sessions, such as differentiating between COVID-19 and dengue, or a session on mental health and COVID. So we're working with our medical and psychological advisors to design these workshops. And we're also just following up and accompanying many different communities in their processes and supporting them in actually adapting their plans. And then we've created a solidarity network as well to connect these community leaders. And I'll just show you a couple of highlights from the communities that we're working with right now. On the two pictures on the left are from a community in Retoca, Honduras. This is a Lenca indigenous community. And their work is being led by it's called the Organized Women of Retoca, so an existing women's group that's really taken the lead on creating their plan and distributing materials to vulnerable groups. We actually just started a fundraiser, which is, and the first donation went to them to create hygiene kits for the vulnerable families, and also giving them out to transit workers, shopkeepers, etc. We'll see a video from them just in a few minutes as well to learn more. And then the photo on the right is of a community in the Peruvian Amazon. It's actually a youth group that is leading, that is using the roadmap to lead the response in the community. And they're also doing a lot of education about ecology and the different kind of medicinal plants in the community as well. On the left here, we see a photo from Tana River County in Kenya, the most recent community to be using the roadmap. And they just also got a donation of soap that they're using. And we're working with a great partner there called the Talent Warriors of Tana River. And they're actually a theater group, and they do local plays to transmit key messages to their community about family planning, about FGM, and most recently now COVID-19. So they've taken on the roadmap to support their community as well. And then on the right, we have a group called Sunun Comunicación in Guatemala, and they work with migrant and indigenous women across the country. Actually, they have different networks, and they are using community radio and also Facebook videos and different social media networks to transmit those key messages as well in several different indigenous languages in Guatemala. And then here as well, we have the municipality of Ixtepec, who's used the roadmap to create a plan. This is an excerpt from their adapted roadmap that they created. And so as you can see, there's many different types of communities and many different sizes of communities and even cities who are using this roadmap. So it could be just a small group within a larger city, or up to the actual health director of a municipality of 25,000 people, such as the case of Ixtepec. And now I'm just going to play a short video from our partner Ecorre in Honduras, and they've been supporting the community of Retoca, as I mentioned. And so they created a short video for us to share a bit about the process and how it was to distribute supplies as well.
Sido bastante bonita las actividades, el entregar comida, ayuda de también de el gel, mascarillas. Ha sido bonito porque hay muchas personas de que no entienden y no saben mucho sobre la enfermedad y el explicarles y el estar juntas es lo más bonito.
Es importante para el CORRE seguir articulando con los pueblos en lucha, dignificando la vida, acompañando con ellos y desde ellos estos procesos. Que se sepa que se está apoyando, pero no de una forma llegar, dar la ayuda e irse, es acompañar también los procesos con ellos. Ellas y ellos conocen mejor las necesidades y desde ellos se construye. Y agradecemos las articulaciones también, estas oportunidades que nos permiten fortalecer nuestro trabajo y fortalecer nuestra visión y construir futuros más justos y espacios más justos también para todos y para todas.
Okay, hopefully that played well. I know sometimes videos don't always work that well through Zoom. And oops, we're just going to the next slide. So with many of these different community leaders throughout Latin America, what we did was to create a regional network of solidarity, and we call these leaders activators. So it's an activators network. And we set up monthly Zoom calls so that they could have a place to talk about the common challenges that they're facing, share some different ideas of how they've adapted the work, the roadmap, and different activities that they're doing in their communities to protect the most vulnerable, to share the key messages, etc. So this is a photo from one of those meetings. And that's been a real highlight of the initiative for many of these leaders, to have that space to share and feel a part of something bigger and really feel that sense of solidarity going forward. So Rachel, do you have anything else to add before I turn it over to Peter?
No, that's great, Jess. Thanks so much for that presentation, and please get your questions and comments prepared, and we'll be coming to you after Peter. So I'm going to introduce Peter next, who's going to really now make the link between this COVID work we've been doing and our TB work, and some thoughts for next steps. So we'll go on to the next slide. Thanks, Jess.
Okay, thanks both. So as with Rachel, I've got a long history with MSF, so working in resource limited settings with regard to both HIV and tuberculosis. So yeah, we're gonna switch from COVID just to TB and talk, I'll talk a little bit about where they overlap and where we could perhaps strengthen TB services. So if you look at the second bullet point there, so if we look at the TB incidence rate in Canada in 2017, it was 4.9 per 100,000 among the general population. So a fairly decent number. That might be the only statistic that a person might see with regard to TB in Canada. But if we look a little bit more closely, there's some problems there. So among Canadian-born non-Indigenous people, so that would be such as myself, the incidence rate is just 0.5 per 100,000. If we go to the third bullet point and compare that to a Canadian-born Indigenous person, it jumps up to 21.5 per 100,000. And then if we look at just the Inuit, so in Canada's north, the incidence rate jumps up to 205. So if we compare the first and the fourth bullet points, we see that there's a massive disparity there. So it's hundreds of times more the risk of an Inuit person having, or an Inuit person having TB compared to a Canadian-born non-Indigenous person. The next slide. So the existing TB model of care in Canada's north is not working at the present time. It's could be described as a top-down approach. So what you get is healthcare professionals who come in on short-term placements to these small communities in Nunavut. They usually do not speak the language. There's perhaps not a good understanding of the cultural, so that ends up in barriers. There's not good communication between the local health center and the community. As a result, the community often knows little about TB. For example, when we went up, not many people understood how TB was transmitted, what it was. So yeah, we had to start with the basics there. In addition to that, there's a general lack of trust in the local health service. It's not, necessarily a result of what's going on now, but there's a long history of TB management in the North that is in part resulted in this lack of trust. So for example, in the 40s, 50s, and 60s, the government sent up a ship to these different communities in the North. These are beautiful seaside communities, by the way. So the ship would travel in the summertime when the ice was not there, and would screen people in each community. So community members would board the ship. They would be asked a number of questions. They'd probably get a chest X-ray in certain circumstances. If they were found to have active TB, they were not allowed to leave the ship at that point in time. So they had to stay on the ship. They would eventually make their way down to southern Canada, end up being treated for TB, which would take a year, 2 years more. Some of these people would die down south. Some of these people might make it back years later to their community. So you had this tearing apart of communities, of families, of even children from their parents. So there's a lot of trauma related to TB over the decades within Canada. So yeah, if a person might think that they have TB, if they've got a new cough, the first thing they don't do is go to their local health center. So they might try other things instead. As a result of all of these factors, we end up with delays in TB diagnosis and treatment. So as you know, this is the worst thing for TB. If you have a person with active disease who's coughing and engaging with other people in the community, you end up with transmission of TB to other people. In addition to that, there's not enough housing in northern Canada in most communities, so you end up with large numbers of people living in the same house, so there's overcrowding there. So yeah, this factor in addition results in the incidence rates that we see there. The next slide. So we'd like to move from this top-down approach to a bottom-up approach, as was discussed, which we've called the community first approach. It largely looks at the initial components of someone presenting with TB. If you go to the first bullet point there, so even though in Nunavut now there's not COVID-19 being within communities in the North, at least not yet, we do know there is some evidence to suggest that a person with TB, that increases their risk of serious COVID-19 disease. So that's not just for people with active TB, but for latent TB as well. So I put a link there to that data. What I would like to comment on next is about diagnosis. So if someone has, someone doesn't present with a diagnosis, in our health facilities, they'll come with symptoms. So if someone has a cough, they should be in many settings not just tested for COVID these days, but in relevant settings for active TB. So Nunavut would be one of those places as well. So if we can take all of these resources that have been allocated to COVID-19 and help improve earlier diagnosis of active TB, this will go a long way towards reducing the burden of TB in Nunavut and beyond. This is also a good time for anybody to know their TB status. So if people have never had a TB skin test, it would be good for them to get tested now. yeah, so as you probably know, people with latent or sleeping TB, they don't have symptoms, they're not infectious, the TB germ is inside them, that their immune systems have sort of walled off that TB germ, but they are at risk of becoming, developing into active TB later on. So those people with sleeping TB can be treated for several months with a certain medication, and that reduces their risk of the sleeping TB turning into active TB. So yeah, if we can take this, this pool of people with latent TB, get many of them treated, we can help reduce the number of active TB cases moving forward. In addition to improving diagnosis, management of contacts, we can take what exists already in terms of managing TB contacts, and use that and improve that, using the resources related to COVID-19. We all know that anybody who's been exposed to a person having COVID-19 needs to have some tracing done and some management as well too. COVID-19, as we know, is largely spread through droplets, but there is a minority of people who are exposed to COVID-19 through airborne transmission. Of note, TB is solely transmitted through the airborne pathway. So infection control measures, there's some overlap there between tuberculosis and COVID-19. So again, if we can take some of the resources allocated to infection control related to COVID-19 and use those to improve infection control measures related to TB, we can go on to reduce the burden of TB. So the community first approach is a bottom-up approach. As we've heard, it empowers communities and involves them in the decision making. It gives them the knowledge to come up with ways to reduce the burden of what we could say would be different infectious diseases in their communities. So we look at that as largely helping to prevent new cases. It's less about treating, it's more about prevention of new cases. And as we say in medicine, the best medicine is prevention. So yeah, so we have this situation now where you have a high burden, TB burden setting, which actually has no COVID-19 apart from in mines, which are separate from the communities, but who are ready to respond to if and when COVID-19 enters their communities. Next slide. So we have a number of activities in Clyde River now and Nunavut. So of note, the primary modes of communication within these small communities would be radio, would be one of the primary ways. Facebook as well as another one. But what we've done is hold radio sessions related to COVID-19. So as you can imagine, there's a lot of, even though there are no active cases in Nunavut at present, there's a lot of interest in knowing all about COVID-19. So people have a lot of questions. So a number of times I've gone on the radio together with some of our local colleagues. So it's done in Inuktitut, the local language. Yeah, we respond to the community's questions. So these are very interactive, very interesting radio shows. We plan on having more in the future, not just related to COVID-19, but about TB as well too, and where they overlap. As alluded to by Rachel, there is a background of mental health barriers there. There's a lot of mental health issues amongst the community members. There's not necessarily good resources available in all communities to manage those. So that's another area where we'll eventually like to tackle in these radio shows. Also, instead of holding in-person workshops, we're planning to have a number of online workshops. Again, these would be held in the local language. They would involve local colleagues who would lead these workshops, and myself and others would play a supporting role. So that would be related to TB and COVID as well too. We'll move from Clyde River to onto different communities within Nunavut. So you have 20 plus communities, small communities scattered throughout the territory, and all of these will hopefully be able to get some strengthened support related to TB diagnosis and management. The next slide. Yeah, so I didn't want to take up too much of your time with respect to TB, but yeah, feel free now to comment or ask questions, and we're happy to take all of them.
Thanks very much, Jessica and Peter. And yes, as Peter said, the floor is now open. Just to wrap up, so kind of just as a few of the comments that have been in the chat have shown, this is really very much about helping communities to empower themselves to be able to respond to health crises, this pandemic, but also other health crises that they're going through. We really believe, as many of you I'm sure will agree, that communities have the answers inside. They have the assets, they have the knowledge, they have that cultural understanding of their realities, but often what they miss is good information, some resources, some tools and some support. And we're trying to bridge that gap. We certainly don't come in with the answers. We really try to work with the communities for them to be able to express what they need and how they want to do it. So that's really the base of it. And so we really know this is about accompanying communities on this journey. And that's why now we've really introduced these ideas of training and workshops and mentoring with individual leaders so that we can really help accompany leaders as they go through, because often it can be a difficult journey, many barriers that they're facing, whether it's with the health authorities or whether they're working on another side like in Retoka, where they're fighting back against a hydroelectric company that's going to really impact their access to water resources. So these leaders are dealing with many issues, plus the impacts of COVID-19 on their communities, where they're seeing their leaders and their elders dying from COVID or getting very sick from COVID. And so there's a huge amount of mental stress. So that accompaniment, that being there, that mentoring is really part of this global kind of approach that we're taking, which we call Community First. So the solidarity part of this is very important, and that's really how it started. So really wanting to be able to reach out in this time of crisis and be in solidarity with people. So I've got Ule Lucy who would like to make a comment. Lucy, can I let you, I'm going to allow you to talk. So you're now able to talk. Please go ahead with your question. You need to unmute.
I was asking, how are you doing the contact tracing? How is the contact tracing being done?
Thank you, Lucy. Peter, would you like to respond to that?
Yeah, so I should say that we're quite separate from the government services there. So we play a supporting role to the community. The government, the health department is in charge of the contact tracing. So they would have their TB nurse, who's usually short term, who would have a few helpers in the community. So I think it's fairly standard. So these communities are all fairly within, homes are within walking distance. So there's probably a lot of home visits in terms of contact tracing and assessment there. So I think it's fairly standard there, but we're on the prior side. So our activities are more aimed at prevention as opposed to the treatment aspects.
And Jess, maybe you could mention some of the resources on the roadmap around contact tracing.
Yeah, so every community is different and is going to have a different level of involvement from the health center. And as we've seen with some communities in Latin America, the health centers are really not involved at all. So we have a couple of different resources about contact tracing on the website. We include it as one of the steps in Respond. And these are, templates for health workers or other types of community workers to do contact tracing. There's, some guides and scripts for how to call people. So the idea is that this roadmap is really adaptable to whatever level the community is going to take on, and to whatever degree of the response the community is going to take on, and can be adapted as well, so that perhaps the health center is really the one who's taking on most of the case detection, contact tracing, etc. And that's why we as well include all of the steps on coordinating with the health authorities, coordinating with the other humanitarian actors in the community, to just know who's doing what, and really figure out where the gaps are.
Thank you. So Cosmas, would you like to ask a question? Hello, Cosmas. I think you're not muted, so maybe the line is bad. Can you? I'm afraid I'm not hearing you, Cosmas. Maybe you'd like to write your question in the chat. Would that be okay? Seems like the line is not working.
Thank you very much.
Oh, I hear you now. Go ahead.
Hello. Hello, my name is Cosmas Muto from Kenya. And mine is more of a comment. It's interesting to know that latent TB, the persons who have latent TB, there's a remedy that they can take so that they don't develop active TB. So I think it's something commendable, and it's something we'll do a lot of advocacy towards. Thank you.
Thank you, Cosmas. That's a very good point. Peter, would you like to comment on that? Or?
Okay, sorry, I missed that. I didn't hear it very well.
Well, Cosmas was saying it was very interesting about the fact that latent TB cannot develop into active TB. I think if I heard the comment properly, and he was just saying it'd be interesting in terms of advocacy. I don't know if there was another point as well, Cosmas, that maybe I missed, because I didn't hear very, very well either.
So there are, there are a number.
You are very right. Yes.
Yeah, so there are a number of treatments that help to prevent the development of latent TB into active TB. The problem is that these treatments are not without risks. So, for example, sometimes the treatments can cause liver problems. Fortunately, there are some newer treatments, so shorter, so 12 weeks or 3 months, with using safer drugs. So if someone has a positive TB skin test, they don't have active TB, so that means they have latent TB. They can get 3 months of 2 drugs given once weekly. That's a new treatment called 3HP, and that can greatly reduce the risk of their latent TB becoming active TB. So in theory, if we did that, within a community, we could greatly reduce the burden of TB in that community over a few short years. So that's the plan. In Nunavut is working together with all of the health partners on a local, territorial, and national level, and that's our goal, is to try and eliminate TB from Nunavut in 10 years. So COVID-19 has sort of interrupted that, but again, we could use all of these resources and consider where they overlap, and perhaps moving forward, reduce both TB and COVID-19 at the same time.
Peter, there's another comment on the chat from Wendy Webesa, who talks about that having a situation with 3HP because of a suspension because of these nitrous. I mean, I don't want to go too far into TB treatments because that's not the goal of this session, but maybe you could just quickly respond to that, or if you have more knowledge.
Yeah, I haven't heard about that with 3HP. I have heard about it with other medications. So Yeah, so that's another setback. That's too bad. So that's going to delay the use of 3HP until they can get that sorted out. But yeah, in the meantime, early diagnosis of every active case of TB. So anyone who's got a new cough really does need to be tested and for active TB, and that test should take place sooner rather than later. So hopefully they get that problem sorted out sooner rather than later, Wendy.
Thanks, Peter. So maybe I can launch a question out to all of our participants. I see many of you are coming in, people from Kenya, people coming in from South Africa, I'm sure many other places that I can't really identify just from your names. So are there any people here who are working at community level who have some thoughts or reflections on whether a kind of an approach like this would be something that would be useful, or if you've seen other approaches like this, or you're involved yourself in approaches like this? It is really about how to get the community at the center to be building their own responses, and maybe some stories that you have or ideas that you have that you'd like to share in this forum. I'll leave a few moments for people to gather their thoughts and see if they would like to.
Yeah, so maybe just while we're waiting, Rachel, I can say that. So I'm based in Ontario in Canada. So Rachel and Jessica are based in the province of Quebec. So both of our provinces are actually seeing quite high numbers of COVID. We're in a second wave where we are now. So the way it stands now is that anybody who wants to travel north into Nunavut has to self-isolate for 2 weeks first. So that's done in a hotel, you know, and yeah, so the government of Nunavut has done a fantastic job of keeping the virus out of Nunavut. So they've done that largely by having people self-isolate for 2 weeks before being allowed to enter. So we hope that keeps up for a long time, but you know, human nature is human nature, and eventually there is likely to be a slip up and the virus is going to make its way into the territory. But so the best, you know, way to manage that is being prepared now, as we've heard.
Yeah. And I think that it's very interesting in Canada, actually, with the First Nations, who also have been extremely active in protecting their communities against COVID. So they took a lot of unilateral action to close their communities to outside visitors, to be checking anyone that was coming into their communities. They put blockades on the roads. One of the things in Nunavut is that these communities are only accessible by air. So there is quite a simple way to stop people coming in. You just stop the air traffic. But in other Indigenous communities or First Nations communities here in Canada, they are linked by road to other towns and also very much engaged and involved with those other towns. So there's been a lot of very strong measures that Indigenous communities have taken on themselves to do, which has helped a considerable amount. Unfortunately, in the second wave, there have been some more cases in Indigenous communities. So they're having to take lots of extra precautions. So, well, I'm filling space a little bit, but I do feel that, you know, if there aren't any more questions that people have,
Wait, Rachel, there are a couple
sorry.
in chat there. So just the Grania mentions.
Okay.
Were there travel restrictions done in partnership with the communities?
Yes, so the First Nations communities in Canada, they just did it themselves. They decided that this is what they needed to do. So they didn't wait for the federal government or the provincial governments to tell them. They took it on themselves to do it. They have a high sense of autonomy in that. So, but the you know, in order to do that, they had to also have the respect of the provincial governments and the communities around them as well. And I think that was extremely successful. And they were also making sure that people left the community, did 2 weeks quarantine if they were coming back in. And I think they've been the strictest in Canada. And the results are that they've had a very, very low amount of community infection. I think one of the big shocks for First Nations communities in Canada was what we saw happening in the Navajo Nation, which, as many of you know, in the US was very early on in the epidemic in North America, was extremely hard hit by the virus. And they lost many, many people. And the Diné people were really suffered extensively. As Peter was explaining before, these are communities that are traditionally neglected, left aside, they're victims of the systemic racism that we're seeing. And they just do not have the same sort of access, or if they do have access, there's often a deep sense of mistrust of the health authorities. And so when we were in Canada watching what was happening in the Navajo Nations, I think that really made people realize that we need to act fast and in advance and not wait for someone to come and save us. It was really communities saying we need to take action right now. So that's just sort of a bit in response to your question, Grania. Nice to see you, by the way.
And just before that, Pumalelo had a good question. She's asking if politics affect the organizational goals. Rachel, do you want to take that one?
It's a very good question. I think that my first sort of more diplomatic answer will be, I think that always global health is affected by politics, and I think health and politics are two inextricable things. I think that we've seen with COVID-19 just how important politics is in addressing health and public health crises. And I think it's something that we all, as the members of this community, need to think about very deeply, how we're going to address this, because we know that decisions have been made based on politics. I mean, our neighbour is the United States, so we live with this reality every day. But here in Quebec, I've seen so many decisions taken on the basis of politics rather than public health. So what is that right balance? Now, in terms of our organisational goals as Sea Change, I think interestingly, it was because of politics that we felt compelled to move to a very community-based approach. When we first went up to Nunavut, we were invited there by the government of Nunavut, and they were very interested in this. We were talking much more about community health worker approaches and task shifting and how to really get that link between the community and the health centre. But we saw that, you know, the way that government is, it moves slowly, it can be resistant to change. Yet the communities themselves were desperate to change and very excited to change. So we said, well, you know, let's let the government do what the government does, but let us really shift our focus to the communities where really change can happen. And so I think if we have a politics that affects us, it's a community first politics and not a partisan politics, but one where we really believe that the community knows best what they need, and with the right tools and materials and information that is true, and the most current and the most updated and the most medically validated and with the most evidence, they're going to be able to move forward. And that's something maybe just to add on the roadmap, is that we do have a steering committee for the roadmap, which is made up of medical doctors, health professionals, so it includes Peter, but 4 or 5 other qualified public health and medical staff who are reviewing all the material, so that the material that on there is always the most recent updated material and is based on WHO and PAHO guidelines, and you know, the guidelines of highly respected and known organizations, so that when communities have access to this information, they know it is true information. They're able to dispel a lot of the myths and rumors and stigma that's going around in many countries about whether COVID exists or doesn't exist, or how it's spread, or what you need to do in order to prevent it. And we do focus a lot on these very simple measures that we've known from the beginning, that if you wear a mask, you protect yourself and you protect your neighbor. If you frequently wash your hands, these are very, very key ways, and do social distancing, these are very key ways to protect yourselves and protect ourselves. So. Comment. So I'm hearing from Uli Lucy, she's saying people are confusing TB and COVID-19 because once you go to the hospital, they test COVID-19, sidelining TB, and at the end of it, you find the person has TB, thus getting TB treatment late. Does that happen any other place? I think, Peter, maybe you have a a comment on that.
So I spent quite a few years supporting TB activities and HIV activities in Southern Africa. And I imagine that's happening a lot there now. I'm sorry, I've been away for a few years from there, but I can only imagine that it's happening. And you add in the factor of HIV as well too. So as we know that TB is traditionally hard to diagnose, more difficult to diagnose in people with HIV. So I can imagine this happening a lot. So a person, yeah, ultimately having TB and the diagnosis is delayed, and as a result, they may infect other people, but not just that, their condition worsens and they have a worse prognosis because of that delay. So, but yeah, maybe other people who are listening now would have a better perspective about whether, you know, COVID is resulting in delayed diagnoses and treatment of TB. Feel free to let us know.
Mm-hmm. I think just to sort of add on from what we've seen in Nunavut, or in the community working in Clyde River, is that the fact that, you know, in January we'd done this trauma-informed community empowerment workshop, people in the community were already much more informed about prevention of TB, and that it was a respiratory disease that passed in droplets and so on and so forth. And so when it came to COVID, it actually was a kind of put them in an advantageous position, because they were able to already understand the transmission. They didn't have to be explained that to them. And we haven't seen any statistics yet, but I think there was a big push in the community for people, you know, if they had any other signs of something that was not COVID, but they had a respiratory problem, you know, a new cough that was lasting more than a certain period of time, etc., that they went to the health centre to get tested. Obviously, at the beginning, it was very difficult to get, you know, people into the health centre. There were lots of concerns about it, but, you know, in that sense, I think that the awareness has been raised a lot. So we hope that that is going to result in more people wanting to address potential TB.
And I might just add, so I work in a community health center now in Ontario, and it's not just, you know, TB that's being you know, having a delay in diagnosis. It's a number of other medical conditions as well too. For example, I heard a story of somebody who was having chest pain, and for some reason that person with chest pain got referred for a COVID-19 test, as opposed to, you know, someone, you know, thinking that it may be related to coronary artery disease and going for, you know, testing more related to their heart. So yeah, it's not just TB, but I think a lot of different medical conditions are suffering as a result.
And I think there's actually something in the roadmap about that, Jess, isn't there, Jessica, in the sustain part of the roadmap about really in part of the sustaining is that people really need to think about, you know, other underlying or coexisting health conditions, and make sure that those don't get forgotten about. And just maybe to add on, we're planning now with the roadmap to bring in a fourth element, which is going to be about recover and reimagine. What we're realizing, which, you know, we started this roadmap right at the beginning of the pandemic from a Canadian perspective. And so we were going with the flow. And of course, 6 months on, we hope we know a lot more than we did back on the 1st of April, or when we first started working on this roadmap. And one of the things we've realized is that this pandemic is not going away in the next couple of weeks. This is going to be with us, and we're going to have to learn to live with this pandemic for at least a year more, maybe longer than that. Let's hope that the vaccine is coming, but that's, as we all know, is not the answer to everything. So one of the things we're going to do now is develop this recover and reimagine part of the roadmap, so people can really start to see, how do you go back to work? How do you go back to school? How do you make sure that you can continue dealing with your other health issues? How can communities organize, and how can we make sure that the mental health of the community stays strong? And this, of course, remember, is often with vulnerable and isolated communities, many of whom do not have very good support from their public health authorities, and really need to take a lot of matters more into their own hands. So we're hoping that that section is going to be a good response to this idea of living in this new normal, the new reality, whatever we want to call it. And Jessica, if you've got anything you want to add to that. I've got one question here I'm going to look at.
I think you covered it, Rachel.
I have another comment here that's been sent me into the questions and answers, saying that there are some regional telementoring sessions in TB, HIV and COVID and mental health using the ECHO model with national TB and HIV program coordinators and medical staff. So it would be, and they've given us an email, it would be great for your community groups to present their work in one of our sessions to get connected to local ministries of health. I just share that in case there's anyone else on the line as well who may be interested in that information. I can't see the name of the person who posted that, but if you're willing, I could also put that on. But I think now the questions seem to have stopped. So I think maybe it's, unless there's any other comments from my co-panelists, my wonderful colleagues, maybe I'll bring the session to a close. I'm sure everyone has been sitting on a lot of Zoom calls today and in recent days.
The thank yous would be
yes, that's right. So I'll go to the end, and I just want to close this session by thanking you all, first of all, for attending, everybody that's on the participants list. These sessions are very difficult to do if you don't feel that there's an audience out there. We can't see your faces, which is always hard, but we make the best of Zoom. And it's really wonderful to have had your questions and see your engagement in the subject. And we really just want to say thank you to the Union for putting on this fantastic conference and having this Community Connect session, which has allowed us to be able to present our project, but most of all, that provides this free forum that anyone can come in, that there's no barrier to entry for anybody, that the community has really got a place where they can come and share and bring their wisdom into a common place. And we have our partners who help put this on. We can't do this, as we said over and over in this session, is that Sea Change is nothing without its partners. And these partner organizations are the ones who are on the ground, who are doing the work, who are really at the front line of these responses. And so we're extremely proud to work with Ilisatcivik in Nunavut, Canada, with ECORE in Tegucigalpa, Honduras, with Las Banderas in Mexico City, Mexico, and with the wonderful talent warriors in Tana River County, Kenya, who use their art to be able to spread the word about COVID. And it's an absolutely wonderful initiative, all of them are. So thank you again. Please, as we said before, please reach out to us. We're very available, very willing, and we would love to be able to help any communities who think that this might be useful for them and could gain from benefit from the resources. You know, this COVID-19 pandemic, we're all in this together, and we're here to support as much as we can. So thank you again, and with that, I'll close the session. Thank you very much.
Yeah, thanks, Rachel.
Yeah, thanks so much. It was wonderful to be here. Look forward to hearing from you.
And Jessica has put her email address inside the chat.
Yes. Please reach out to us. We would be happy to meet one-on-one or with a group of individuals who are interested in using the roadmap, and we can go through in more detail and see how best we can support.